Thank you very much, Magdalena. Peter, thank you so much, and to you and the entire group of organizers who saw fit to start this conference with a talk on peritoneal dialysis. We have only, 12–13% of the US dialysis population utilizing peritoneal dialysis. Of course, that's about to increase over the next few years to 80%. But maybe 25 or so. So high-quality PD, what does that mean? How do we achieve it? What do we need to do? So learning objectives upon conclusion, hopefully we'll be able to identify clinical parameters that correlate with survival in PD patients, recognize that it's so much more, and perhaps even to the exclusion of small solute clearance, and describe the application of goal-directed dialysis. So we'll talk about two things, survival and goal-directed dialysis. I'll come back to elaborate on the meaning of that in a few minutes. But I think it's important to recognize that these, while our two goals, are not necessarily in every circumstance congruent. So survival. Are there one or more clinical parameters which, when a certain level or range of values is achieved, predict or are associated with improved survival compared to that observed in patients who have not achieved this same level or this same range? There are many clinical parameters that we could discuss. For those of you who are agnostic or atheist, I prove to you that there is a God, because when you list these in alphabetical order, small solute clearance comes out at the bottom of the list. It's okay, go ahead. So, acid-base status. Here's a study out of China. It's a relatively modest-sized study, some 450 patients, looking at the association of, or the relationship between serum bicarbonate and mortality in peritoneal dialysis patients. On the left, all-cause mortality. On the right, cardiovascular mortality. And you can see that in the blue line, you have patients with a time average bicarb of 24 or above. Then beneath it, those with a bicarb in the intermediate range of 22 till 24, and patients who fail to achieve a serum bicarb of at least 22 in the bottom line. And you can see clearly that whether we're looking at all-cause mortality, cardiovascular mortality, there is a difference. And looking at it in a different distribution, you can see that there is an increase in the hazard ratio for mortality as one gets below a bicarb of 24. I reside at altitude, my patients reside at altitude. We all have a respiratory alkalosis. We all have a compensatory decrease in our serum bicarbs. Normal bicarb for me is 22. Does this differ at altitude? I wish I knew the answer to that. Blood pressure control. This is a small study from the USRDS looking at the relationship between systolic blood pressure and mortality. You can see that compared to the reference range of 111 to 120, as blood pressure increases, there is no change in mortality, but as blood pressure falls, as systolic pressure falls, there's an increase in the hazard ratio for mortality. So this would suggest that we want to keep patients' blood pressures at least a systolic of 111, but not to get excited if it's 160, 170. Now, this may simply reflect the fact that mortality in the population is so high that we can't dissect an effect due to higher blood pressures. I'm not advocating that we keep patients at exceedingly high pressures, especially in light of this study that comes from the United Kingdom, a slightly larger study, where they found indeed that a higher blood pressure is protective in the first year of PD, but it's irrelevant, or there's no effect in years 2 through 5, but by the time we reach year 6, which unfortunately not that many PD patients in this country make it to year 6. Hopefully that will change. But by the time we reach year 6, there is indeed a deleterious effect of increasing systolic blood pressure. So the take-home message to me is we should be at least 111, maybe 140, 150s, doesn't matter, but I'm certainly not endorsing keeping patients at higher blood pressures. What about volume homeostasis? We all know that maintaining volume homeostasis is important. Is Joel here, Joel Glickman? No, Joel gave me this slide, and I think it's wonderful. You know, volume is the uremic toxin, right? Because it's retained in renal failure, it's biologically active, it exerts deleterious effects on body function, and removal improves outcome. So water is bad. And here you can see some old data from Turkey looking at total fluid removal. This is the sum of peritoneal ultrafiltration and urine output, and you can see that more is better. The more that patients remove daily, the better their outcomes. And this is data from the EPO study, also kind of long in tooth by now, but you can see that the higher the peritoneal ultrafiltration, better than 750 ml per day, patients fare better than if they have less ultrafiltration. Of course, this is a surrogate, in a sense, for overall volume status, because a patient may remove 2 liters a day, but if they ingest 3.5, they're not going to fare well. Conversely, the patient who removes only 700 ml per day, but ingests only 800, 900, 1,000 is going to do well. So what is important is overall volume status. N-terminal proBNP serves as a surrogate for overall volume status, and you can see that the lower the N-terminal proBNP, i.e. less stretch on the myocardium, patients do better. And this is a relatively recent study looking at the predicted total body volume from a model that has been verified and established, and the comparison by bioimpedance of the patient's actual volume status. And you can see that if a patient is more than 17.3% volume expanded, it is associated with an increased hazard ratio for mortality. So nothing new here. We all intrinsically know this. The problem we're stuck with, of course, is how best to assess volume status. I'm not aware of terribly many units routinely utilizing bioimpedance for every clinic visit. At a minimum, of course, we should have no overt signs of volume overload. We don't use diuretics enough. There is a study in hemodialysis patients appeared just a few months ago indicating that patients who continue to fill prescriptions for loop diuretics fare better than do those who are not taking loop diuretics. Similar data, this is as yet unpublished, from Brazil, where you can see that the hazard ratio for mortality in either incident or prevalent patients is lower in the patients utilizing diuretics. And I would maintain that we don't use robust doses of diuretics in the United States. In Europe, we have patients taking 500 milligrams to a gram twice a day. They're not all walking around with hearing aids. They're doing quite well. And here in this country, when I tell people that I'm prescribing 240 or occasionally 320 milligrams twice a day, it raises eyebrows and people question my sanity, for many reasons. So, why might volume overload confer an increased risk of mortality? Obviously, LV mass, CHF, hypertension, cardiovascular events, but there may be a relationship with inflammation. And does it behoove us to monitor for inflammation? Well, at this point, I can't yet say yes, because I don't know what I can do about it when I find it. Although I believe there was data at ASN, I didn't make it to the late-breaking clinical trials, but there is an anti-inflammatory molecule that does improve outcomes, apparently. So this is a study out of the Karolinska Institute, small study, but you can see that the patients who have the higher C-reactive protein are more likely to have poor fluid removal. So with volume overload, there is an association with inflammation. And inflammation, as shown by this study by Angela Wong in Hong Kong, is associated with poorer outcomes, higher CRP, poorer survival. We get to some electrolytes, potassium. Potassium less than 3.5. Again, Hong Kong data is associated with increased mortality. Similar data has been obtained elsewhere. Here's US data showing a U-shaped curve using the range of potassium 4 to 4.5 as the reference range. As potassium falls, and remember, of course, in peritoneal dialysis, hypokalemia is far more likely than is hyperkalemia. as potassium falls below 4, there's an increase in either all-cause mortality, cardiovascular mortality, and infection-related mortality. And this is data, similar data from China, similar data from Brazil, again showing on the left two panels overall and cardiovascular mortality, and on the right, infection-related mortality. So it behooves us to maintain a serum potassium at a minimum of 3.5, if not 4.0, in our PD patients, sometimes a challenge in patients who have no potassium in the dialysate and don't eat sufficiently well. This infection-related mortality may relate to an increase in the frequency of enterobacterial peritonitis with hypokalemia. Again, data from Hong Kong looking on the left panel at the frequency of peritonitis about threefold in patients with a serum potassium less than 3.5. And if you look in the right-hand panel at the distribution of the organisms, you can see that enterobacterial things, E. coli, Klebsiella, Citrobacter, etc., are higher, and this may relate to decreased peristalsis, increased time for transmural migration. Some question about the reproducibility of this. The PDOP study, I'm told, has not yet demonstrated this, but it remains to be determined with certainty whether or not this is a real relationship. Sodium, interesting, because if you look at this data, this is US data, you can see that as serum sodium falls below 136, we begin to see an increase in mortality. Anybody ever see a PD patient with a sodium below 136, right? And with an increasing serum sodium, at least above 144, I don't know how high they went, there seems to be no associated increase in mortality. And this is data out of the United Kingdom that shows that there's actually an increase even with a sodium less than 138. For all I know, my sodium is 137. And this is interesting that at 138 there might be a difference. Why might this be? Possible reasons: cerebral edema with cognitive disturbances, encephalopathy. There are impairments in cardiac conduction that I cannot explain because of inhibition of calcium channel circuits. I never understood that stuff. And then there's infection-related things, impaired host immunity, impaired local host defenses. So you might wonder, is there an increase in the frequency or severity of peritonitis in patients? Here you can see that in hemo patients, this is the only hemo slide that I'm showing you, there is indeed an increase in infection. Time to first infection is shortened, and as you can see in the right-hand panel, some of that infection is gastrointestinal, even in the hemodialysis patients. So what relationship is there between sodium and mortality in PD? Increased infection-related mortality in the hyponatremic patients. And while there is no increase in the frequency of peritonitis in hyponatremia, shown peritonitis episodes 22%, 30%, no significant difference, hospital mortality is massively increased from 1.4% to 26% in the presence of hyponatremia. And hyponatremia is something, I get the sense that we don't always pay sufficient attention to the hyponatremia. Those of you who utilize icodextrin will know that you sometimes see a 2 to 3 milliequivalent per liter decrease in the serum sodium due to the osmotic effect of the maltose and maltose multimers. Does that make a difference? Don't have the data. Mineral metabolism. I'm running through things because there's a lot. Mineral metabolism. Calcium, you can see whether you look at the uncorrected or corrected. For albumin, the curves shift a little bit when you correct, but basically between a corrected calcium of 9 and approximately 10.5, mortality remains at the reference range. Once calcium goes either above or below that range, we start to see increases in mortality. Magnesium, something that I at least don't routinely monitor in all of my PD patients, and I'm beginning to wonder if I should. Again, taking patients in the normal or below normal range of serum magnesium, 1.7 basically milligrams per deciliter as the cutoff, and you can see that patients with a lower serum magnesium have an increase in either both all-cause and cardiovascular mortality. And phosphorus, we live and die frequently by 5.5. We torture our patients and tell them that they have to have a serum phosphorus below 5.5. The data in PD at least doesn't support that. And in this study, this is, I believe, a DaVita database, you can see that there is no increase in mortality demonstrable until we reach a phos of at least 6.4. So I tend to get a little bit more lax with my patients who have a phos of 5.8, 6.0 than I do with those with the higher serum phosphorus. And small solute clearance. You've already ascertained my attitude towards small solute clearance, so let me tell you about two of my patients. Which patient is receiving better renal replacement therapy? I have one patient who's extremely lethargic. He can walk 15 minutes and then he poops out. He complains, I can't do anything. He looks bad. He's got a blood pressure of 101 and an albumin of 3. And then I've got a patient who golfs 9 holes 3 to 4 times a week. He occasionally forgets to come to clinic because he's out on the golf course. And he says, oh, I forgot that I'm supposed to see you. I feel great, best that I have in years. He looks great. He's got a good blood pressure. His albumin is 3.9. So what are the KT over V ureas going to look like? You can guess, right? The guy who can't function has the KT over V of 2.0, and the guy who's doing great has the KT over V of 1.5. What's the difference? Probably the residual kidney function that the second gentleman has that the first patient did not. But I think it's time to really retreat from this reliance on KT over V urea. And that provides a great segue to the new Ispd guidelines, which I understand as of today, coincidentally, are available online. And let's go back to the old guidelines for a moment. The 2006 guideline from the Ispd Adequacy of PD Working Group stated clearly that adequacy of dialysis should be interpreted clinically rather than by targeting only solute and fluid removal. Clearly more to adequate dialysis than a focus on small solute kinetics. Then they came up with this 1.7, and unfortunately people have been literally living and dying by this 1.7. The problem is that people don't go back to the original document and realize that the adequacy is meant to be more than small solute clearance, and pegging the KT over V has come to mean in many people's mind that we have adequate dialysis. By the way, what does adequate mean? Just enough, right? If I told you that your performance on something was adequate, you wouldn't be thrilled. You'd like to know that you had done well, if not extremely well. So what do we mean when we're talking about dialysis being adequate? So the new guideline group began meeting about a little over 2 years ago. There's global representation, and the discussion focused on the need for patient-centered recommendations. Small solute removal will remain in the mix, but is downplayed as it should be. I personally think it should have been downplayed even more. But we know that there are limitations in the measurement of KT over V, particularly the inaccuracy of determining V, and the trials, of which there are very few, right? We have the Atomex study, we have the Lowe study out of Hong Kong, and Linda Fried study, that the adequacy trials do not meet scientific rigor. There is very little high-quality evidence. Again, adequate in the thesaurus, satisfactory, tolerable, acceptable. Should PD delivery really be just adequate? So for the new guidelines, we're not talking about dialysis adequacy. We're talking instead about prescribing high-quality, goal-directed peritoneal dialysis. So what does goal-directed mean? It means we have to do the unthinkable and speak to the patient and find out what he or she actually wants out of life. We use shared decision-making between the patient and the care team to establish realistic care goals that will allow the patient to meet his or her own life goals and allow the clinician to provide individualized, high-quality clinical care. And I'm being rather a little cynical and sarcastic about doing the unthinkable and talking to the patient, but this does take time. It takes more time than it does to simply say, you did or did not meet 1.7, and we will or will not adjust your prescription. SONG PD, Standardizing Outcomes in Nephrology for Peritoneal Dialysis. Alison Tong has spearheaded these, and there has been a group for peritoneal dialysis. And these are what the patients rank as the important outcomes to them: avoidance of infection, fatigue, mortality, achieving flexibility with time, etc. You can read the list as well as I can. But what's notably absent is anything that cites or even relates to small solute clearance. Potential elements to consider. I'm not going to read all this, but small solute clearance way over on the right-hand side at the bottom of the list. And the focus of the recommendations from these new guidelines for prescribing high-quality PD is the need for patient-centered care. And the important thing was that they wanted to be all-inclusive and talk about the frail patient, the patient with comorbidities. Because we're an international organization, we looked at low and low-middle income countries as well, things that may not pertain to the United States specifically. And we looked at new changes, in a sense, which is the concept of incremental peritoneal dialysis. So shared decision-making, no more mind games. No more attempts at mind reading, simply have the discussion. So the headline recommendations. PD should be prescribed using shared decision-making between the person requiring dialysis. By the way, we're getting away from the concept of patients and with person-centered care. We're talking about people performing peritoneal dialysis rather than peritoneal dialysis patients. Patients don't want to be defined as such just because they perform peritoneal dialysis. PD can be prescribed in a variety of ways, should take into account local resources, the person's wishes regarding lifestyle, and the family and caregiver's wishes if they are providing assistance. Bullet 3 is the meat as far as many of us are concerned as relates to small solute clearance. We are talking about a health-related quality of life that needs to be assessed on a routine basis. Are you satisfied with what's going on? Appropriate adjustments in care should be made based upon these assessments. Volume status. High-quality PD prescription should aim to achieve and maintain clinical euvolemia, taking into account residual kidney function and its preservation. Again, how do we assess euvolemia? I don't have a readily available clinical tool that I can use on a routine clinic visit that is easy, but I can at least assess for the absence of edema, the absence of RALs, and the absence of overt signs of volume contraction. Blood pressure should be included as one of the key objective parameters. There is no hard data, as I showed you just a few minutes ago. I think there's clear data that you don't want to have too low a blood pressure. How high can you safely allow it to go may depend on the patient's vintage, but I'm paying less attention to the patient who comes in with a consistent blood pressure of 150 over 90, is already on several antihypertensives, including an ACE inhibitor or an ARB, which, by the way, are beneficial for the preservation of residual kidney function and for the health of the peritoneal membrane. And I'm willing to let that slide. I think the data supports me in that assessment. Nutritional status. Biochemical plasma markers, including potassium, bicarb, albumin, and phosphate, should be regularly measured. Unfortunately, albumin, prealbumin. Many of you, those of you who take care of patients, know that you can have them eating 2 sausages for breakfast, a burger for lunch, and a steak for dinner, and the albumin is still 3.2. And that probably reflects inflammation more than it does dietary intake, and it's not easy at all to influence that. And finally, small solute clearance. They didn't wipe it off the page entirely. They say it still should be routinely measured using either KT/V urea or creatinine clearance. This can guide the amount of dialysis prescribed while recognizing the limitations of accuracy. I think the most important things are what follows. There's only low-level evidence showing that increasing urea clearance has any impact on the quality of life, technique survival, or mortality. And part D, if symptoms, nutrition, and volume are all controlled, no PD prescription change is needed for the sole purpose of reaching an arbitrary clearance of small solute molecules. So I think that when you have your patient with a KT/V of 1.5, I almost wish we could move to the Canadian system where my colleagues tell me they just don't bother routinely measuring it. But if you have a KT/V of 1.5 and your patient is thriving, I think it's cruel to force that patient to do more dialysis just so some person somewhere, without using any pejoratives, will be satisfied that the KT/V has reached 1.7. Residual kidney function should be determined for all patients doing PD, and management should focus on preserving this function. For some individuals, and this is where we get to person-centered care and health-related quality of life, particularly patients who are old, for frail patients who have multiple comorbidities with a poor prognosis, there may be a quality of life benefit from a modified dialysis prescription to minimize the burden of treatment and not pay as much attention at all to the other parameters. Keep the patient feeling well, functioning well, doing what it is she or he still wishes to do and enjoys doing, and not worry about the other parameters. Low and lower middle income countries, I think we can forego. The principles of prescribing and assessing delivery of high quality PD to children are the same for those of you in the pediatric population. The PD prescription should be designed to meet the medical and psychosocial and financial needs of the child and their family. Again, a very personalized approach. So sort of in summary, we recognize that some parameters are more in our control than others. We can more readily deal with the bicarb by providing more dialysis or prescribing sodium bicarb. By the way, all this data that I've shown you is associational or observational data. We don't know that taking someone with a serum bicarb of 21 and then prescribing sodium bicarb to bring it to 25 will in fact change their survival. So that's a very important caveat. I think these are important associations. I think we should strive to achieve the appropriate levels or ranges, but I can't prove to you that doing so is the right thing to do or will have the desired outcome. So in summary, survival of PD patients is best if they exhibit a normal volume status, a systolic pressure of at least 110, if they're not inflamed, if they have normal levels of sodium, potassium, calcium, magnesium, a FOS under 6.4, a bicarb of at least 24, and while I didn't show you the data, residual kidney function of at least 1 ml per minute. And finally, the delivery of high-quality, goal-directed PD requires a person-centered, individualized approach with tailoring of the prescription to the patient's well-being, lifestyle, and quality of life, adjustments depending on residual kidney function, volume status, and to a lesser extent, dialytic solute removal. For those of you who would like to learn more, please join us in Glasgow at the beginning of May for the World Congress of the Ispd. And right on time, thank you.